Professor Tayyeb Tahir has come in today, and I'm delighted he could come and join us and share his expertise with us. Tayyeb, I want to ask you about delirium in particular because it's a hot topic in the literature, but it's an area where people are not certain necessarily about that terminology. And I just wonder if the general population, in a way, know what we mean by delirium. What is delirium essentially?
First of all, thank you. It's an important area of our clinical work, day-to-day clinical work. Lots of people who come into hospital experience delirium. And what recent classification system has done is that it's brought a number of terms under one umbrella called delirium. Post-pump psychosis, confusion, post-operative confusion. They've all been put together in one term called delirium. Sounds scary, but it's a very common presentation. About 15% of people who come into hospital can suffer from delirium. Now, what it is depending on who we are seeing. Some people present with more complex symptoms of delirium, and some people might have more simple symptoms of delirium. But they are all concerning. As a clinician, it's important to identify those symptoms and manage those symptoms appropriately. So what it means is that people can present with as simple a presentation as confusion, disturbance of sleep. Some people present with more complex symptoms like misinterpreting things that are there. And some people present with hearing voices, but they're short-lived. And there are a number of descriptions in literature where people present with some paranoid thoughts. So it all depends on who you're seeing, and it's important for doctors to have that knowledge to identify. And also it's very important for nurses, carers, family members to be able to identify what delirium is on these lines, these symptoms that I've just described.
So it's quite a common but diverse syndrome. What's its significance in terms of outcome? Is it one that has invariably a bad outcome? And why should we be aware of delirium?
Fortunately, most of the time delirium is short-lived, but then there are people who can suffer from delirium for a long period of time if not treated properly. Usually delirium has a cause, an underlying cause, for example, a physical illness, infection, as simple as a urinary tract infection or upper respiratory tract infection. It depends on who you're dealing with. Someone fit and healthy might suffer from delirium if they undergo a major operation. Someone who is frail, elderly, might suffer from delirium from a very simple infection which might not bother some of the other people. So it depends who you're dealing with, but majority of the time it is short-lived. Sometimes it's long and prolonged course of illness, and sometimes people have these spikes over a period of time. Therefore, it is important that it is identified and managed appropriately.
There is a link, however, with a very bad outcome, which is mortality. Why is delirium linked with mortality, in your opinion?
Delirium is linked with mortality, increased length of stay in hospital, and increased further chances of developing delirium. And there are a number of theories behind that. There could be a chemical change, neurochemical change within the brain. It is sometimes the effect of delirium on the brain itself that can result in prolonged illness, and especially in those who suffer from dementia. It has been demonstrated their dementia symptoms suddenly get worse after an episode of delirium. So again, there could be a number of reasons why people can have a bad outcome from delirium episode.
Are there any high-risk conditions which link themselves with delirium? You actually mentioned one there, dementia. But are there any other high-risk conditions or situations where clinicians or patients would be more likely to think, delirium could develop here?
Yes, it's important to identify the etiological factors or risk factors, because someone who is, like I mentioned earlier, elderly, frail, someone who's got debilitating physical illness, undergoing a major surgery. They're all high-risk patients. Someone with a past history of psychiatric illness, they could be at a high risk of developing delirium. So that's why it's important to identify those patients, the risk factors within those patients, and trying to preempt a good nursing care before they develop delirium.
Okay, so that's a very interesting aside. Can we intervene in those early stages? Maybe delirium's not developed, but they're in that at-risk group, to prevent that number of people who are developing delirium. Is there any good evidence for preventative strategies working?
I think the most important factor is identifying, providing good nursing care, making sure that they are looked after in an environment by people who understand delirium. That's why carer education and education of nurses around the topic of delirium is important. Now, there are some studies, some research that has been done on a good medical care, a comprehensive, integrated medical care where physicians, nurses, physiotherapists, occupational therapists, they can identify delirium and make sure that the symptoms of delirium are not brushed under the carpet because of what they are going through as a major illness. And hence they perhaps need to bring in some intervention measures like making sure they're looked after in an environment where there's appropriate optimal daylight cycle. They are looked after by nurses who are familiar with the patient rather than a different nurse every couple of hours, making sure they are looked after in an environment of less stimulus, and making sure that their independence is encouraged, their confidence is built without really confronting them or colluding with their fears. Those are the first important steps to consider. And then there could be other things that can be done and that have been researched upon, which include the physical or biological treatments with medication. There have been some studies where sedatives, major sedatives have been given to prevent delirium developing. And once delirium develops, then a number of other strategies can be put in place in terms of controlling this syndrome. Sometimes the word treatment is used, but I think it's more important to manage the whole syndrome in a very biopsychosocial model, i.e. using medication, using some psychological techniques, and using some social interventions.
If you were a family member who thought your nearest relative had a delirium, is there anything that you can do in that situation?
That's a very important question because we rely a lot on the relatives for information, from carers for information for us to make an appropriate decision on what to give as medication, as far as medication is concerned, but also giving advice on simple things like visual aids, hearing aids, reorientating them, giving them a newspaper, reading a newspaper with them, making sure they know what time of the day it is, and making sure they know what time it is on the clock. So those simple reorientating measures are important as well as a relative. But more importantly, it's information that they can pass on to people in hospital or nursing homes for early identification of delirium, because there is some research where they say people who are going to develop delirium, they start buzzing for help, their sleep-wake cycle goes haywire. So if they can identify those symptoms early on, perhaps appropriate advice can be given before full-blown delirium can develop, i.e. subsyndromal delirium can be dealt with.
What is the role of a familiar face, i.e. somebody the patient previously knew and had trusted. Could that be a relative who comes in? Would that be an appropriate role to make them more comfortable? Or maybe a member of nursing staff who could have that role?
Absolutely, you're correct on that. Someone who is familiar, it gives confidence to the patient. I know this person. They are less likely to misidentify that person. And because they can't misidentify that person, they will perhaps trust that person more. And hence it becomes easier for people looking after to communicate with the patient as well.
Do you have any words of advice for clinicians who are trying to get more familiar with this area? They want to look out for delirium, but they're not entirely sure what strategy to use. Is it something where they can default to a scale, or should they read up about the symptoms and signs, or should they just be aware of those patients who, are not quite fitting with the normal recovery trajectory that we're used to seeing?
There are a number of scales that the clinicians can use, but nothing is as good as sitting with the patient and getting that information. And that information should include confusion, level of confusion, lack of attention and concentration, and other things that I've mentioned earlier on for visual perceptions, hearing voices, or paranoid thoughts. And then it's also important to remember that delirium could be of 2 or 3 different types. Some people are more agitated and some people are less agitated. And it's well known, people who are agitated, they're easily identified and referred to psychiatrists. But those who are not agitated, they can be misdiagnosed. And that's why it's important to talk to those patients about confusion, memory testing, so that we can help them early on by diagnosing them properly and not diagnosing them with depression rather than delirium.
Well, Tayyeb, that's been a really excellent overview of delirium. I think you've gone a long way to giving some important cues and tips to helping not just the public recognize this important syndrome, but clinicians who perhaps aren't as familiar with it as you are. So thanks for coming in today, and I really appreciate you sharing your expertise with us.
You're welcome. It's been a pleasure talking to you, and I hope this is very useful for people who look after patients with delirium.
Thank you very much.